يكون شغال. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. It is my great honor and pleasure today to introduce this exceptional webinar. We have exceptional presenter, Dr. Gloria, and two famous and well-known high caliber and eminent professor of critical care and well-known internationally, post-professor Javer Press and Professor Adel Sisi. And I am so pleased to introduce this webinar. Firstly, we will have a short presentation presented by Paulo Javer, which is MED candidate 2024, University of Virginia, and her topic is improving perioperative evaluation with wearable devices from inside the Wellcome study. I'm so pleased today to have Professor Javer. He is Chief Operating Officer and the Medical Director, South Florida Critical Care, and he is President-elect of World Federation of Intensive and Critical Care. Of course, he is the Medical Director of Critical Care Services, Baptist Hospital, Miami, and of course, he is the Council Member Federation Pan-American, as well as being Associate Director of Sleep Medicine, Larkin Palm Spring Hospital, many, and huge and voluminous CV, Dr. Javer. God bless you. It is my pleasure. It is my pleasure also to introduce Professor Adel Sisi. He is consultant intensivist and chief medical critical care and prime health care group and chair of ICU unit. Has PhD from Cairo University. He is distinguished institutional officer of Dubai residency training program. Also, he has a huge CV affiliated to Arab and Emirates board, instructor in American Heart Association Advanced Cardiac Support, and he is reviewer and published many critical care books. It is my pleasure and honor to have this exceptional webinar. Thank you for your time and your effort.
Thank you. Thank you, Dr. Safa. It's already actually our pleasure to join this session, inshallah, with our colleagues, and wish for the audience, inshallah, to get the maximum benefit. Thank you, Dr. Safa.
Thank you for your endless support for the online program of Egyptian Society of Anesthesiology and Acute Care. Now, Paula will present her presentation.
Hi. Thank you, Dr. Safa, for no, it's on my phone. No. Thank you, Dr. Safa, for that excellent introduction. And I'm really excited to be here and participate in this webinar. And thank you for the other doctors, presenters, and speaker and moderators that will be here to share their knowledge on such a complex yet interesting subject. So without further ado, we'll get started. Like Dr. Safa mentioned, I will be presenting on a topic, specifically improving preoperative evaluation with wearable devices. And I dove deep into a study called the Wellcome Study. So the question I asked myself was, can medical professionals leverage commercial wearables for improving preoperative assessments? As most of you already know, increasing life expectancy and comorbidities lead to more complex surgical procedures, specifically in elderly patients and frail patients. Despite lots of medical advancements, cardiovascular and perioperative complications still remain a problem in the perioperative care. So I asked myself, do wearable devices play a role in medical assessment? And if so, what role do they play? And can they be implemented in our healthcare system? So there's a need for risk estimation. Complex surgeries require accurate risk assessment to be able to predict which patients will need the most care. There are some existing scales, as you know, the ASA classification system is one. There's also the clinical frailty scale used to assess frailty in individuals based on functional capacity, independence, and mobility status. There's also the MET, which is used to estimate the metabolical of patients' physical activities. And there's Duke, the Duke activity scale. Index. All of these existing scales are often used, yet they do present many limitations, specifically due to their subjectivity, and they are known to also have some poor predictive value. So there is a gold standard, and that's known to be the cardiopulmonary exercise test, but yet that's still pretty expensive and time-consuming. So the 6-minute walking test has been known to be a good alternative, which is a bit more inexpensive and a bit quicker, with a good predictive value for patients who have comorbidities such as chronic obstructive pulmonary disease or other such diseases. But they does have its limitation as well, as it requires in-person assessment, which could be a burden both for the healthcare system as well as the patient and caretakers. So wearable devices refer to a broad category of devices equipped with sensors that can track various physiological parameters, such as heart rate monitoring, activity tracking, and sleep monitoring. They range from medical grade wearables, which are designed specifically for healthcare applications, to commercial smartwatches like Apple Watch or Fitbit and Samsung, which are available to consumers. They have gained significant attention in recent years due to their potential to provide continuous and non-invasive monitoring outside of traditional healthcare systems. And in addition to being inexpensive and non-invasive, wearable devices offer the convenience of remote monitoring, which allow patients to undergo preoperative assessments in their own environment without the need of frequent hospital visits. So overall, wearable devices have the potential to improve the efficiency, accuracy, accessibility of preoperative evaluation, and ultimately can lead to better surgical outcomes. So the Wellcome study specifically is a prospective observational research study. The objective of the study was to assess the correlation between the data obtained from a wearable device and conventional preoperative evaluation measures. So the goal was to determine whether information gathered through these devices can provide valuable insights into patients' health status and risk factors prior to a surgery. The participants that were studied, the specific patient population studied in the Wellcome study were high-risk individuals age 70 or above, scheduled to undergo general anesthesia, as this patient population tends to be have multiple comorbidities and have increased surgical risk. So the overall the Wellcome study represents an innovative approach to leveraging wearable technology in the context of preoperative care. So in the case of the study, individuals met the following criteria to be included. They had to be the age 70 or older, and surgery that they were about to entail had to exceed 2 hours to ensure that they were going to be in significant amount of stress during anesthesia. The following were exclusion criteria for the study, and that was inability to consent, urgent procedures, or limited mobility. In this study, the researchers provided the participants with a Fitbit Inspire 2 wearable device for a duration of 7 days before their surgery. For those that don't know, the Fitbit Inspire 2 is another wearable activity tracker that's available to consumers that monitors various physiological parameters such as heart rate, physical activity, sleep patterns, and steps taken. Immediately after the inclusion and while wearing the devices, participants underwent the 6-minute walking test as part of the preoperative evaluation. Clinical parameters such as respiratory rate, Borg scale, blood pressure, the heart rate were acquired before and after the completion of the 6-minute walking test in patients. Additionally, those participants enrolled also conducted a standard anesthesiological assessment, which included airway assessment, ASA classification, MET, Duke Activity Status Index, and clinical frailty scale. So 43 patients were screened. Eventually, 29 were analyzed for complications, with the majority being men, 71% being men, with a mean age of 76.1. Like mentioned previously, the baseline characteristics from the preoperative clinical evaluation scales were recorded, and the patients underwent the 6-minute walking test. To determine whether patients presented with reduced exercise tolerance, a threshold of 350 meters was chosen for this 6-minute walking test. That was chosen based on published literature. Around 45%, 14 patients were not able to surpass a distance of greater than 350. That said, around 55% were able to have surpass 350 meters and were hence said to have a good 6-minute walking test. And most patients that were able to exceed the 350-meter threshold in this test also had the average daily step count of above 10,000 steps. So in other words, patients with better performance in the 6-minute walking test tended to have higher physical activity as measured by their daily steps recorded by the wearable device. So this figure above depicts the 3 clinical evaluations analyzed according to 2 factors. Those 2 factors being the 6-minute walking test and the wearable device baseline activity levels. And they're pretty comparable, as you see. And here you could see that there was a significant positive correlation with a coefficient being 0.56 between the logarithmic transformation of daily step counts and the 6-minute walking test. And of course, I would like to mention that there were additional findings and secondary outcomes to the study, but in the interest of time, I won't dive into too much detail. But I do like to mention that the study examined associations between other metrics recorded by the wearable device, such as total calories burnt and minutes spent in high intensity activity compared to the 6-minute walking test results. And some of the results of these comparisons also showed significant correlations, indicating that these metrics as well could serve as indicators for functional capacity. So talking about implications and future directions, well, by collecting data on physical activity, heart rate, other relevant metrics, wearable devices can serve as a substitute for traditional preoperative assessment measures, offering a possibly more convenient and potentially more comprehensive approach to monitoring patients' health status. They're thought to be pretty cost-effective. Using wearable devices are around, if buying one on the market could be around between 60 USD to 100 USD, compared to traditional in-hospital tests like the 6-minute walking test, which could cost a lot more. Wearable devices enable remote monitoring for patients' health status, allowing healthcare providers to track patients' progress and intervene as needed without the need of frequent clinical visits. And wearable devices can support and provide personalized healthcare, tailoring specific healthcare plans to individual patient needs and preferences. So like in all studies, this study did have some limitation. Firstly, this was a pilot study, so it did have a small sample size. And like in any other study using digital health technologies, there is a risk of missing or unreliable data due to device malfunction, participant compliance issues, or other factors that may overall just compromise validity or reliability of a study and may require careful interpretation or analysis of available data. But despite these limitations, there is promising potential of wearable devices in improving preoperative evaluation process. Wearable devices can provide valuable insights into patients' health status and functional capacity, which may complement or even enhance the traditional preoperative assessment used today. There is still need for further research to validate and expand upon the findings of this pilot study, including a larger scale study with more diverse patient populations and longer follow-up periods. This is my reference in case you guys would like to read into it more, and I would like to open up the floor for any questions, comments, or concerns. Thank you.
Great. Really
Thank
great
you, Paul.
presentation. Paula, thank you for the effort and your time and the right presentation. Now the floor for Dr. Adil to introduce Dr. Kalari.
Thank you, Dr. Safar. Thank you, Dr. Fakro, for this important topic and the study. And hopefully in the future also for the use of technology and the digital transformation will help the anesthesia doctor and the ICU doctor to get more accurate information from these wearable devices and non-invasive, more convenient to the patient and easier to use. Thank you so much, Dr. Paulo. Now it's the time to go through one of the most important topics in critical care medicine and consider serious and fatal condition if not early detected, diagnosed, and if not treated, which is subarachnoid hemorrhage. Nowadays, we can see many patients have sudden headache, severe headaches, and after coming to the emergency department, even younger age, we can find those patients after the first CT scan, it shows there's subarachnoid hemorrhage. That's why we'll go through more information about this with our eminent speaker tonight, who is Dr. Gloria. Dr. Gloria, she's from Puerto Rico, and she's internal medicine and critical care and neurocritical care specialist. She graduated from the School of Medicine and finished her internal medicine residency at the VA Caribbean Healthcare System, and afterwards completed her critical care medicine fellowship at TMH Brown University. She returned back to Puerto Rico to continue and to direct the VACHS surgical ICU for 6 years. After that, she went to direct the UDH neurosurgical ICU. She moved in 2010 to direct the neurosurgical ICU at the HEMA San Paulo, and a private hospital there. And after that, she worked as posted as assistant professor at the University of Puerto Rico School of Medicine. Dr. Gloria also, she is currently involved in numerous national and international societies. She is a council member of Society of Critical Care Medicine and president of COXACTI. And she is former council member of FEPIMCTI and past president of the Puerto Rico Society of Critical Care Medicine. She has been a speaker at the local, national, and international level, and had publication in peer-reviewed journal, authored book chapters, and co-editor of the books of critical care medicine. She also had this topic about comprehensive clinical guide and COVID-19 pandemic, lesson from the front line. She lives happy with her beautiful family. Let us welcome Dr. Gloria, and let us go through this journey of talk and presentation with subarachnoid hemorrhage. Let us welcome Dr. Gloria altogether. Thank you.
Thank you, Professor El-Sisi, and thank you, Professor Hallel, for the invitation, the Egyptian Society of Anesthesia and Critical Care, and also thank you to our esteemed moderators for joining us and sharing some time, and thank you, the audience, for taking interest in knowing this about this topic that is I'm very passionate about. We're going to be talking this evening about the management of aneurysmatic subarachnoid hemorrhage. I don't have any conflict of interest to disclose. And we will be talking about recognizing the signs and symptoms of subarachnoid hemorrhage. How are we going to implement clinical and diagnostic evaluation when we suspect a subarachnoid hemorrhage? We'll talk about the initial evaluation, the importance of early treatment and resuscitation in these patients. So before beginning a little bit, we need to review our anatomy of the vasculature, especially the arterial vasculature of the brain, including the circle of Willis, the basilar arteries, anterior circulation, posterior circulation, because aneurysms usually form in these bifurcations where the intima of the blood vessel is debilitated, and that's where aneurysms form. So that's the beginning of why a ruptured aneurysm and subsequently subarachnoid hemorrhages. We usually have an incidence of 2 to 22 persons per 1,000 per year. Out of all the 3 cases of strokes, ischemic, hemorrhagic, and subarachnoid, this is one of the lesser ones, but it's one of the most devastating ones, accounting for 3 to 5% of all stroke cases worldwide, with a mean age of 51 years. Women are at increased risk than men, and so are Black people, and also people from Japan and Finland. But what about the stroke burden in Egypt? This is a series, meta-analysis of 5 epidemiological studies. And what has been found is over the years, there has been an increase in prevalence of stroke in the area, with some areas more represented in these studies, but still there is an increase in the stroke. So that is something that you need to look about, because it is a very debilitating disease. Also, when you look at the 3 types of stroke, you can see there's also an increase. This is newer data going up till 2019. And the importance of this is the World Health Organization has the CD goals, and this is one of these goals of preventable and non-communicable diseases, trying to decrease these non-communicable diseases. And as you can see, the incidence of subarachnoid hemorrhage, which is the one in green, as you see, the incidence in stroke is increasing, but also incidence of subarachnoid hemorrhage has not changed much over the years. So we will be talking about this later on in our lecture. How can we address this? Risk factors, we have preventable and modifiable risk factors and non-modifiable. Modifiable risk factors include smoking, use of tobacco, alcohol consumption, history of hypertension. If there's a family history, also it happens. Use of hormonal replacement. And then also, since we spoke about how aneurysms form and the debilitating layers of the vessel, then any disease that is associated with a debilitating or collagen disease will be also affecting, such as quartification of the aorta, polycystic kidney disease, Moyamoya disease, Ehlers-Danlos syndrome. So the mortality rate, this is data from 2001, based on England. Usually this is a neurological emergency. The 24-hour mortality is 21%. At 7 days, it's 37%, and if left untreated, up to 50%, reaching 50% up to a month. And there's a relative risk in patients that are in the upper age, 60 years, versus children, which is increasing. One of the other things that we use is and why this data is based on this, is the Hunt and Hess classification, which is from 1968. Which found that a ruptured asymptomatic aneurysm had a low mortality rate, but as you went up on your grade and developed deep coma, rigidity, and you were moribund, it approaches 77%. So one of the things that we need to have caution with these mortality rates is throughout the years, these have declined as we have become more involved, recognizing the urgency of this disease and newer interventions, but we still need to think that there's still a quarter of the patients die within 24 hours. There's a 40% mortality at 30 days, 50% mortality at 6 months. And if there's rebleeding, there's a higher mortality associated with that rebleeding. And this is data from 2018. So yes, we have made some advances in regards to morbidity and mortality, especially mortality, but there's still a long way to go regarding this disease. So when I look at subarachnoid hemorrhage, I divide it in several ways. One of them is our diagnostic approaches. How do we manage that aneurysm, be it surgical or endovascular? And then the rest, right? Like I call the rest, which is on your right side column, which are critical care issues that are inherent to any critically ill patient. The big three related to subarachnoid hemorrhage, which is rebleeding, hydrocephalus, and vasospasm. And also other related to the subarachnoid hemorrhage, but are not part of the big three, which is neurogenic pulmonary edema, cerebral cell wasting, and other complications that we'll be talking about. What are the clinical features of a subarachnoid hemorrhage, aneurysmatic subarachnoid hemorrhage? So the classic is abrupt onset, worst headache of your life. It's a new, different type of headache associated at times with nausea, vomiting, neck pain, because that is signs of meningeal irritation. There might be a transient loss of consciousness and even associated coma, and it relates to the burden of the amount of blood that has been in the subarachnoid space. And also the nature of that headache distinguishes itself from other onsets of stroke. Ischemic strokes, hemorrhagic strokes, there might be a little bit more subtle in the way as opposed to this classic presentation. But there are also not so classic presentations in which the headache is not as abrupt. It responds initially to non-narcotic analgesics. So probably this person thinks that might have a migraine headache or a normal headache. Take a little acetaminophen, paracetamol, and then it will, resolve on its own, but then it will come back. And then those patients will then have a worsening headache, worsening neurological status. And 40% of these patients, they might have a normal or intact neural exam without evidence of meningeal irritation, and they will not necessarily appear acutely ill. And usually those relate to our Hunt and Hess patients, grade 1, grade 2. Key features when we're communicating a patient with a subarachnoid hemorrhage to one of our colleagues is, number one, to use the Hunt and Hess clinical grading scale. It's a way, number one, to, as we spoke earlier, to predict morbidity, mortality, but also it tells you about the severity of this subarachnoid hemorrhage. Also, when you're communicating, use your Glasgow Coma scales. How are the pupils? If they're reactive, non-reactive, how many millimeters? A fundoscopic exam, and we'll show a picture of this later, looking for retinal hemorrhages, and also your neck exam, looking for signs of meningeal irritation versus just neck pain. Another scale that we can use is the World Federation of Neurosurgeons, in which it also uses not only a motor deficit, but it integrates your Glasgow Coma scale into their scoring system. And this is the grade. There are several apps that you can use in your cell phones that can help you do this scoring system, the World Federation or the Hunt and Hess. And we'll be talking about other scales, radiographic scales that are also useful to have and have them handy. So this is how you usually, when you have somebody with hypertension, you usually are used to seeing flame and dot hemorrhages. But somebody with a subarachnoid hemorrhage, you'll see a classical subalioid hemorrhage. So I encourage you to do fundoscopic exams on your patients who come into your ICU or ER with a subarachnoid hemorrhage. One of the things that we also use are brain imaging studies, and the non-contrast CT of the brain is the standard for identifying a subarachnoid hemorrhage. It is helpful not only for identifying subarachnoid hemorrhage, but somebody comes with a headache and neurological signs and symptoms that are suggestive of stroke. It will help you in identifying if this is an ischemic stroke, a hemorrhagic stroke, or a subarachnoid hemorrhage. So this is the gold standard. It's mostly available, and it's something that can be done quickly. It's very sensitive. It's nearly 95% sensitive for recent subarachnoid hemorrhage, but that sensitivity decreases over time. And if you can see it, by 1 week, it goes down to 50%. And then at 2 weeks, it goes down from quarter to 30%. You can have also negative, false negative CT scans of the brain if you have somebody who's got severe anemia, if you have a low volume subarachnoid hemorrhage. So it's very important to be very cognizant of the history and the clinical exam. These are signs of more subtle subarachnoid hemorrhages, so you got to get used to seeing and reading non-contrast CT scans, right? Because you can have a little bit of blood in the sylvian fissure, you can have a little bit of blood into the interhemispheric fissure, and these at times, especially in the interhemispheric fissure, can be confused with calcification of that fissure. So you have to be very subtle and look for that if the history and clinical exam point towards a subarachnoid hemorrhage. On the contrary, this is a very dense subarachnoid hemorrhage, and also include an interventricular hemorrhage. And to that effect, we also have another scale, the Fisher and the modified Fisher scale, which talk about the thickness of that subarachnoid hemorrhage, if it's diffuse, if it's thin, or if it's thick and localized, and if there's interventricular hemorrhage involved. And the reason and the significance of this scale is that you can also associate that as you go up on your grading, the incidence of symptomatic vasospasm and delayed cerebral ischemia, which, as I said at the beginning, it's one of those big three that have an impact on morbidity and mortality on patients with a subarachnoid hemorrhage. One of the things that some physicians, and I'm involved, and myself included, is that we advocate coupling that CT scan with a CT angiogram at the time of the CT scan. And one of the reasons is I work in a primary stroke center going into a secondary and comprehensive stroke center. So when you couple that, you get more information if it's if we're talking about strokes, if there's a large vessel occlusion. But now that we're talking about a subarachnoid hemorrhage, we can also look for an intracranial aneurysm and then implement treatment strategies very early on. One of the things that might be of concern is regarding renal function. Usually we're trying to use non-iodine contrast material, limit the amount of administration of contrast to try to, and hydrate these patients, try to minimize that risk of acute kidney injury. But when you have that and you couple it, you have a sensitivity for detecting of aneurysm from 98% to almost 100% specificities in series. So it is very useful, but the negative predictive value is less clear. So if you have a negative CTA, you can't rule out a subarachnoid hemorrhage. And if the clinical history, going back again to the importance of that history and physical exam points towards an aneurysm, then you have to keep looking and try to rule out that aneurysm. The other thing that you can use is an MRI. These are useful in patients who have come later on, more than 12 hours following a subarachnoid hemorrhage. Specific sequences can be useful for detecting these heme products. And then, of course, our gold standard would be going for a cerebral angiography, which is useful not only for the diagnosis, but for treatment of that aneurysm, right? If still you have doubts regarding your CT scan, your MRI comes negative, and you still have a clinical suspicion, you can do a lumbar puncture. The lumbar puncture, if the CT is negative and it's still suggestive of a subarachnoid and the patient came in later on, more than 2-3 days, then you can identify xanthochromia, and that is by the breakdown of heme products. And usually it takes time to develop. So if you do it early on, you won't find it, but it takes a little bit of, half a day for it to develop, and you'll see it. And you can see the tube here. You have clear CSF. That's how CSF is supposed to look. but then you can have this heme tinged lumbar puncture CSF. So how do you interpret when you do a lumbar puncture? Your typical finding is you're going to have a lot of red blood cells that are not clearing from tube 1 to tube 4. No or very small amount of white blood cell count. You're going to have a WBC to RBC ratio from 1 to 700. You're going to have that xanthochromia, and your opening pressure is usually elevated in 2/3 of your patients. When it's not suggestive is if you have no xanthochromia, your opening pressure is normal, you don't have any RBCs, or it clears from tube 1 to tube 4, right? And then if you have something inconclusive, is when you have something in between, you have clearing of your RBCs, but you have a ratio that's high, but not suggestive of other processes. So that's very important. One of the things, and if you end up from this lecture remembering this slide, I've done my job. Subarachnoid hemorrhage is a vascular emergency. It has to be treated promptly because of the high morbidity and mortality associated if we don't secure this aneurysm early on. There are times that I've had colleagues talk about a window of no treatment in the acute phase because of all the inflammation. Please, there is no window of treatment. It is a vascular and neurovascular emergency that has to be treated promptly. There are two sets of guidelines that have come recently. One is the American Heart Association, the 2023 guideline for the management of patients with subarachnoid hemorrhage. This has been endorsed by the American Academy of Neurology, American Association of Neurological Surgeons, and also the Neurocritical Care Society. It'll be known also that the Neurocritical Care Society also published in 2023 another set of guidelines for the management of subarachnoid hemorrhage. They're not contradictory, they're complementary in terms of the emphasis of the multidisciplinary approach, the acuity of the disease, but also focusing on improving long-term outcomes. The Neurocritical Care Society has the emergency neurological life support. They have an algorithm for the management of subarachnoid hemorrhage that I encourage you, if you're interested in neurocritical care, into taking this course for the emergency neurological life support. So when we're talking about aneurysm management, there's a big decision that we need to make. Early securement of the aneurysm is of the utmost importance. The question is it going to be surgical or endovascular, the approach? One of the things in making the decision is what you have readily available. If you have neurosurgery available, but you don't have endovascular, then, by all means go for the neurosurgical approach. If you have endovascular, but you don't have neurosurgical, go for endovascular. If you have both, there's some literature that points you towards one versus the other. Something very important was this study. This was the ISET study, which compared clipping versus coiling in patients. And this study favored endovascular approach, and that's what has been a big paradigm shift in the management of subarachnoid hemorrhage, right? One of the advantages is that you don't have to do a craniotomy. The access is endovascular, less comorbidity, in terms of also of the concerns of the surgical approach. So this is a basilar aneurysm before coiling. You can see it here, your aneurysm, and this is after it's been coiled and addressed. One of the advantages of endovascular treatment is that you can sometimes reach aneurysms that through a surgical approach would have been much more difficult, and the risk for bleeding, for more damage to other important structures is also avoided. But still, there are decisions that need to be made. One of them, if with endovascular, if it was a white neck, if it was a big aneurysm, it would have been harder for doing endovascular treatment. So there's still a role for surgical treatment. And this is one with clipping of the aneurysm. This is an image of clipping. with the advancement of different endovascular techniques, where we have jailing, stenting, the coiling, we have pipeline stents, we have different things that have come up. Sometimes aneurysms that were not for endovascular approach were not now they are becoming highly accessible endovascularly. So now we're still gearing a little bit more away from a surgical approach. And these are recent studies, this one's from 2019, of comparison of stent-assisted versus non-stent coil embolization and the safety and effectiveness of this. Because one of the concerns was when you're doing coiling or stent-assisted embolization, the risk of thrombosis. So these patients in the acute subarachnoid phase had to be giving dual antiplatelet therapy or other options to prevent that thrombosis. And then that created other concerns regarding if the patient needed some type of intervention, ventriculostomy or treatment for other conditions. And having these patients with dual antiplatelet therapy, that posed a risk for hemorrhagic complications that were associated not because of the subarachnoid hemorrhage itself, but because of these stents and coiling. But then these studies have been coming up, especially from Japan, where having stent-assisted coiling with dual antiplatelet might be a viable option, even in the setting of acute subarachnoid hemorrhage. And that is what we have been seeing further on. So hopefully we'll get more data regarding this. One of the things, and I can't not overemphasize, is when we're talking about treating patients with subarachnoid hemorrhage or any critically ill patient for that matter, is having a focus on patient-centered care. When you have somebody with a subarachnoid hemorrhage, you want these patients to have bed rest. It doesn't mean absolute bed rest, but have them avoid any type of exertion, avoiding noises, bright lights, treating pain and anxiety, because these things can also promote rebleeding in a patient who still hasn't had an aneurysm secure. Having family members available, a humanized ICU, including brochures, lights on, lights off. These things focused on patient-centered care have also had a positive impact on patient outcomes. So when we're talking about a patient with subarachnoid hemorrhage, usually divided on two phases, the early phase and the delayed phase. And each phase has a focus and a pathophysiology involved. So it's very important to recognize this. The early phase is that period within the first 72 hours of onset. That's when the aneurysm is ruptured. That's when there's hemorrhage, there's transient global ischemia secondary to that type of blood, and there's early brain injury associated to microcirculatory constriction, endothelial cell apoptosis, the disruption of the blood-brain barrier, and some type of brain edema associated to that endothelial cell disruption, apoptosis, and the blood-brain barrier. There's also a release of catecholamine release, and that creates a sympathetic hyperactivity, and that can create cardiopulmonary complications, which is very important to be aware of them, and we'll talk a little bit about that later on. After that first 72 hours, we go into the delayed phase, and our main concern is the delayed cerebral ischemia, which one of the definitions is a focal neurologic deficit that lasts over 1 hour. And they are usually not apparently immediately after occlusion, because if it happened after immediate occlusion, then you would think it's a complication from either that endovascular procedure or that surgery. And also very important to exclude other causes of a neurological deficit, such as metabolic, hypoglycemia, seizures, but that's very important. So this should be considered the same way we consider stroke as an emergency, a vascular emergency in terms of ischemia now, where you need to reinstitute reperfusion. The pathophysiology from ischemia related to stroke is different. So then there are other things that we need to take into consideration in our treatment diagnosis and a treatment plan. So when we're doing this, being aware of this early and late phase, what are the methods that we have for diagnosis and monitoring of these patients? Number one and foremost, our neurological exam. We need to do frequent neurological exams. These patients are usually admitted into a neuro ICU, and they get that neuro exam. And if there's a deterioration, then we take some type of action. The other one is do, like we mentioned before, some type of angiography, be it a CTA, MRA, or a DSA, and that will tell us about the vascular anatomy of these patients, regarding not only if there's an aneurysm present, but also if there's any hemodynamic abnormalities related to the circulation. Maybe we can diagnose vasospasm, right, in that term. Like we said before, CTA or CT perfusion, it will tell us about not only the anatomy, but if there's some type of perfusion deficit, and if we need to do some type of augmentation of perfusion, of brain perfusion, to assist in that deficit. One of the things that are commonly used, and sonography is no stranger also to neurocritical care, is doing daily or frequent transcranial Dopplers, and that will tell us a little bit more about that circulation. And we use it as either screening and monitoring of that delayed cerebral ischemia / vasospasm. In more advanced centers, we can also use cerebral microdialysis. And this has been associated in academic centers to an increase in lactate pyruvate ratio that you can see even before clinical appearance of signs and symptoms of delayed cerebral ischemia. So that's something very important, especially in patients with a high-grade subarachnoid hemorrhage, that we can't do frequent neurological exams because they're not awake or following commands to be able to do that type of monitoring. Brain tissue PO2, also this has been restricted to very specialized centers, but when you see brain hypoxia, you can also infer that there's ischemia going on. Near-infrared spectroscopy is something that is emerging. It's readily available at the bedside, so it's something also that we'll be looking towards more data coming out regarding NIRS. So when we're talking about subarachnoid complications, like I said before, the biggest three, rebleeding, and that one is usually solved early on within the first 24, 48 hours of securing that aneurysm, either surgical or endovascular. The other two, hydrocephalus and cerebral vasospasm, we'll talk a little bit more. Other things that can happen, volume status alterations, a smaller status alteration. So we need to monitor those electrolytes and the volume status of these patients. Occurrence of seizures, arrhythmias, like we mentioned, there's a sympathetic discharge that can be promoting arrhythmias or other complications, such as Takotsubo cardiomyopathy, a global hypokinesis secondary to that catecholamine surge. And then those patients can go into congestive heart failure. CNS infections, especially if there are devices such as a ventriculostomy or these monitoring devices. We spoke about brain tissue O2 or microdialysis, and complications related to critical illness, being in the ICU, nosocomial infections, catheter-related infections, DVTs. So when we're first thing, rebleeding, unsecured aneurysms, there's an increase in the rate of rebleed per day, as long as we don't secure that aneurysm. That's why there's an urgency to do that. One of the things you can do is give antifibrinolytic therapy that's not suggested to go beyond 24, 48 hours, especially if the person is going to go for open surgical intervention and clipping of that aneurysm. Trying to minimize pain is also very important, and minimal but no, or no sedation to allow for the exam. So there's a balancing act there, right? Trying to give that analgesia, but with a minimizing sedation and trying to avoid that rebleeding. If there are any coagulopathies, we need to correct them. Usually our goal is to have an INR less than 1.4. Our platelets should be more than 50,000. Blood pressure management and the guidelines from the American Heart Association and the Neurocritical Care Society usually talk about avoiding a systolic blood pressure of greater than 160 to avoid rebleeding. Over-treating that blood pressure, trying to get it lower, less than 120 systolic, might be problematic because it can potentially lead to cerebral ischemia. So once we have a secured aneurysm, we allow for higher blood pressures. If you are treating blood pressure, you should use short-acting, titrable intravenous medications. So that way you can have that window of fast on, fast off, low, easily controllable blood pressure. This is a very poor picture, but it's one of the books, and it had been around for a while now, but it's still very good in terms of what are your blood pressure goals in subarachnoid hemorrhage, because it divides it between if there's evidence of clinical vasospasm or no clinical vasospasm, and if the aneurysm is secured or not secure, and what should your blood pressure target or MAP should be. And basically, if you have somebody who's aneurysm insecure, you can tolerate MAPs greater than 120 millimeters of mercury. But if you don't have a secured aneurysm, then you should go for lower targets, maybe even 110 or 100 but MAP, but still don't go lower than that 160 systolic. The second big of the big three is hydrocephalus. Hydrocephalus is a clinical symptom, right, of increased intracranial pressure. You have a CT scan that's usually associated with ventriculomegaly. In here, we can see your third ventricle is very big. You also have transependymal migration, which is seeping of CSF through the ventricles into the parenchyma. And you can tell that this is associated with a subarachnoid hemorrhage and also intraventricular hemorrhage, and that's what's causing these obstructive hydrocephalus. The treatment is a ventriculostomy. We need our colleagues neurosurgeons involved in this. And usually, and it depends on how high or how low you're going to have your ventriculostomy. Usually don't go lower than 10 millimeters of mercury. You can go 15. It depends on the amount of blood and also on the level of increased ICP, trying to lower that ICP, trying to get that CSF with blood coming out, right? Those one of the things. Another thing that's good in diagnosing early hydrocephalus, and we spoke about this earlier, is if you have somebody who has had an aneurysm that has been coiled, maybe that neurosurgeon would want to place a ventriculostomy before making the decision of coiling that aneurysm, because of the things we spoke about early on of having to give dual antiplatelet therapy if you use stent-assisted coiling or not. But that's one of the things that you might consider. It is also helpful to have a ventriculostomy because it can help you diagnose rebleeding. This patient had the clear CSF we saw 2 slides earlier, and then all of a sudden you see this gush of blood coming out, and this is somebody who rebled, and we were able to diagnose it not only through the clinical exam because the patient complained of a headache, but also because we saw actually the blood coming out, and that was a sign of rebleeding. Call the neurosurgeon, take the patient to the OR immediately. One of the things that's very important is preventing, since you're having now a ventriculostomy, is catheter-related infection or a ventriculitis. And that's one of the things that's very important to cover these EVDs, maybe have antibiotic-coated catheters or even some type of antiseptic antibiotic gel solution applied. One of the other things that you might want to consider is if you have that amount of burden of blood, you can know it's going to take a while before that blood is reduced and diminished. So one of the questions would be, what is the role of intrathecal fibrinolysis in subarachnoid hemorrhage, especially patients with intravesicular hemorrhage? And it's a very good idea. It comes from the CLEAR study in intracerebral hemorrhage and IVH associated with intracerebral hemorrhages. And one of the things is doing fibrinolysis. It decreased poor neurologic outcomes, decreased the incidence of delayed intracerebral ischemia and chronic hydrocephalus, but there was no big difference on the occurrence of new hemorrhages or even on morbidity mortality. So this is something that is usually, at this point, it's up to the center and the team to discuss if they're going to do intrathecal fibrinolysis for subarachnoid hemorrhage. One of the things we've done in our hospital is if we anticipate, because of the amount of blood, that there might be clotting of the ventriculostomy, then we consider doing intrathecal fibrinolysis to avoid that and avoid the further burden of having somebody either change that ventriculostomy or the risk of deterioration because of acute hydrocephalus secondary to clotting of the ventriculostomy. The third big thing we'll be talking about is cerebral ischemia after subarachnoid hemorrhage, what we commonly know as vasospasm. The thing is, there are different types of ischemia. One of them is what we call early ischemia, which is either secondary to acute vasoconstriction. One of the management is to keep that blood pressure up. Either ischemia also because of decreased cerebral perfusion pressure secondary to increased intracranial pressure secondary to hydrocephalus. So that one would be treatable with placing a ventricular drainage device. Ischemia related to myocardial injury because of that catecholamine surge causing low cardiac output, low cerebral perfusion. And then if the problem is underlying myocardial injury, then you might consider some type of inotrope treatment to treat that early ischemia. And that usually occurs on day 1 and day 2. The one that we usually also can talk about is ischemia secondary to the aneurysm treatment, be it endovascular or surgical. We spoke about this, and this is usually a complication from the surgery. And then the one we all know, it's more considered the delayed or the late ischemia, usually happens from day 4 till day 15, peaking on day 7 to day 10, and basically most commonly associated to vasospasm, for which we're going to talk about. Usually give prophylaxis with nimodipine. You increase the blood pressure, trying to increase cerebral perfusion pressure, and also take that patient into the OR for endovascular treatment, either with intraarterial vasodilators or angioplasty or a combination of both. Also, the less common known are because of cortical spreading ischemia and also delayed neurological or systemic complications causing delayed ischemia, such as seizures, hydrocephalus, infections, and pulmonary edema. But usually we speak about vasospasm as the one of the big three, right? Along with rebleeding, hydrocephalus, and then vasospasm. So when we're talking about vasospasm, it occurs in 70% of our patients. It's the majority of our patients will have vasospasm at some point during their stay. And that is one of the reasons why they also stay in the ICU for this type of monitoring. The difference is that symptomatic ischemia only occurs in 30% of that patient, thankfully enough. So we usually divide these two between radiographic vasospasm and clinical vasospasm. And clinical vasospasm is the one that we're going to be treating. And this is most common between day 4 and day 10. And like I mentioned before, the peak happening between day 7 and day 10. Here you can see a patient who's had vasospasm. Here you can see the small arrows. You don't see that well, the vessel. And then here you can see somebody who's got intervention, intraarterial vasodilators, and how that vessel now looks from that very good caliber. So one of the things that for prophylaxis, number one, that amount of clot removal we spoke about early on when we were talking about the Fisher scale and radiographically, ways that you might decrease that clot burden, which is associated with late ischemic damage. The other thing is maintaining euvolemia. We're no longer doing what was used to be called Triple H therapy, hypervolemia, hypertension, hemodilution. We no longer use Triple H therapy, but we do maintain euvolemia in these patients. Volume expansion is not useful. Nibodipine, 60 milligrams Q4 hours for 14 to 21 days. That has been proven to have a relative risk of stroke reduction by 0.69. Its standard of care should be given. Outside the United States, if you don't have nibodipine, you can use nicardipine, which is an equivalent, but in the US, still not FDA approved for that purpose. There has been several things because most of the mortality associated to subarachnoid hemorrhage has been related to rebleeding and hydrocephalus, but most of the morbidity and mortality has been associated to this delayed cerebral ischemia. So much has been studied and tried in trying to add on to the reduction and the prophylaxis. So one of them was using intravenous magnesium for subarachnoid hemorrhage as a prophylaxis. This was done in 2010. The IMASH study, sadly enough, there was no difference with regards to treatment or no treatment. So one of the things is we don't give magnesium infusions to patients with subarachnoid hemorrhage to avoid vasospasm, but do keep a normal magnesium 2.2, avoid hypomagnesemia. Another thing that was studied and also without favorable results was using of statins. There's a component of inflammation involved in vasospasm. So giving statin as an anti-inflammatory, initially, there was a study that would compare placebo to 40 of simvastatin, and there was a trend toward decreased mortality, but then a STASH study found no difference. So we also do not use statins as prophylaxis for subarachnoid hemorrhage and vasospasm in these patients. But if you do find that these patients have hypercholesterolemia and an LDL of greater than 100, then by all means treat their hypercholesterolemia. Another big one had been used, clazosentan. This one is an endothelin receptor antagonist. In single studies, there was some promise, but also did outcomes in subarachnoid hemorrhage in clinical trials. So that is something that we do not recommend at this point. The ELISA study had some promising results. ELISA-1, this was the use of albumin for 7 days. It was tolerated in patients with subarachnoid hemorrhages, no major complications, and showed promising neuroprotective effects. ELISA-2 is underway, and we're looking forward to having results from this ELISA-2 study. Another role for neuroprotective drugs has been sulfonylureas. This is the GASH study that had been done, and there's a growing interest in these patients. Literature first comes from TBI, now going into subarachnoid hemorrhage, so we're still also looking for results. There's one going on in Brazil, and looking forward to see if there's a role for sulfonylureas in patients with subarachnoid hemorrhage. This is a very good review. I can, if you want to look for it, this was published in 2016. In terms of the pathophysiology of delayed cerebral ischemia, but still, there's hope for future trials, but no evidence to support the use of clazosentan, magnesium, or simvastatin in this group of patients. So what is it that we do have for treatment? Nimodipine, yes. All patients should be treated immediately after the diagnosis. No role for magnesium. Statins, as I said, patients who are on chronic therapy for hypocholesterolemia should remain on that. Antifibrinolytics, no role for decreasing morbidity, mortality, or maybe for the clot burden in terms of obstructing EVDs. Antiplatelets, also no role for that. No role for AAA. And endovascular treatment, very likely in terms of if treatment failure medically, then you take these patients to endovascular, either angioplasty or vasodilators. And this is something that's emerging more now when we are focusing on time is brain. And if you have somebody who's showing signs and symptoms of delayed cerebral ischemia, and after half an hour, 1 hour of medical treatment, patient doesn't improve, you should call your neurosurgeons or your endovascular surgeons for treatment. Seizure management, patients with unsecured aneurysms, if they have seizures that can lead to rebleeding, so prophylaxis is usually administered. There's cones and cones. Phenytoin has been going into disuse because of worse cognitive outcome. Keppra has been in the upscale now. And one of the strategies is load these patients until they're secure and then stop any anti-seizure medication after there has been securement of an aneurysm. Like I said before, levetiracetam is one of the alternative anticonvulsants that has been coming in vogue now because of the safety profile and these not association of worse cognitive outcomes. If the patient does have seizures, treat them as any seizure protocol. And always, even if there's just one seizure, get a CT scan to look for any changes in intracranial pathology that might need intervention. Lorazepam, first line of treatment to avoid seizures and avoid progressing into status epilepticus. Going after the big three into other important complications and critical care problems in these patients are what we mentioned before: cardiovascular and neurogenic pulmonary edema, usually secondary to this sympathetic hyperactivity and excessive catecholamine. Symptomatic occurs in 20% of patients with subarachnoid. 80% will have detectable oxygenation abnormalities. So monitoring these patients and their saturations is very important. And here are the mechanisms, as we've mentioned before. You treat accordingly. If it's somebody who's got low cardiac output, consider inotropes. If it's volume overload, consider diuretics or vasodilators. Also, these patients need telemetry monitoring because they can also have ECG abnormalities. Most of them will have inverted or isoelectric T waves, but they can also have SCT segment changes, QT prolongation, U waves, bradycardia, tachycardia, you name it. Anything can happen with a subarachnoid hemorrhage in terms of ECG abnormalities. Other non-neurological complications, and here's their incidence. Fever. Fever is usually related to central, but before calling something a central fever, it should be a diagnosis of exclusion. Always consider ruling out an infection, a DVT. Anemia also happens basically because of the frequent blood monitoring and sampling that we do. Hyperglycemia, these patients are critically ill, so they secrete cortisol. And hyperglycemia in all neuro patients has been associated to worsen neurological outcomes. So, control of hyperglycemia should also be in your priorities and in your order sets as you manage these patients. Hypertension can be multifactorial. We usually allow higher blood pressures, and it will occur in terms of cerebral autoregulation and keeping CPP, but we usually don't treat hypertension in these patients unless it's too high. Hypernatremia, these patients can present both hyper and hyponitration. Natremia, hypernatremia could be also a sign of volume depletion, and we want these patients to be euvolemic. So be very, monitor those electrolytes. Pneumonia, and as we mentioned before, hypotension, pulmonary edema. Hyponatremia can be secondary to cerebral salt wasting syndrome, and it's the most common cause of hyponatremia in subarachnoid hemorrhage, as opposed to syndrome of inappropriate ADH secretion, which is very common in other neuro patients and in other hospitalized patients. But in these patients, it's usually cerebral salt wasting syndrome, and it's associated with volume depletion, not volume overload. Prophylaxis of venous thrombosis in these patients, it is recommended in all patients with subarachnoid hemorrhage. If you can't give pharmacologic prophylaxis, then do mechanical, but once an aneurysm is secure, you can go for prophylactic pharmacologic prophylaxis of VTE. early recovery and rehab, and we're almost finishing, is very important, and it yields improved outcomes. And we should not wait for a patient to be out of the ICU before we start early rehabilitation, early mobilization. One of the things that we've done is if the patients are bedridden and we don't have the resources to have automatic pedaling and preventing deconditioning in our patients, we use these pedals. And then either the patient does it or we have the healthcare provider do the cycling for them, but it prevents deconditioning. And then the other thing is, if you notice, we can take patients out of bed, and if you notice, this patient has a ventriculostomy. So having a ventriculostomy placed is no contraindication to having a patient mobilized out of the bed into a chair. And look at that smile. She's very happy that she's out of bed. This was a novel study in patients with subarachnoid. Their ICU stay when you implemented that study was 3.5 days earlier than the 10.5 days in the control group. Improved cognitive outcomes, less fatigue and less sleep disturbance at 30 days. And then costs were lower in patients that went to the early rehab group and was related to shorter ICU and hospital stays. So what is the prognosis? Patients usually either from 10 to 20% of our patients, they don't get to the hospital. They die before they get access to medical care. 1/4 die within 24 hours. As I said, 50% mortality at 30 days. And 1/3 of those who survive with early intervention, 1/3 of those will still have a disability. So there's only a small group of patients who's good results after a subarachnoid hemorrhage. So it's very important. So to end, I want to leave you with this message of hope and what it means thinking outside the box or getting out of your comfortable pond and going into other ponds, like a fish going into another pond. If you look at mortality rates from, and this was in Canada, from 2004 to 2015, you can tell that these mortality rates have been decreasing, survival has been improving. So we should not, and we cannot afford to accept these horrible numbers that we've been mentioning throughout this hour and a half, because there's still so much to do. There's still so much from the pathophysiology of subarachnoid hemorrhages that we don't know, and so many areas of intervention that we cannot accept these numbers and keep looking for better outcomes. And there's small things that we can do right now today, such as early intervention, early diagnosis, modification in terms of public health policy, modification of risk factors, getting data on what is the incidence of subarachnoid hemorrhages in your country. And as I said, in terms of early intervention, early diagnosis, early securement of this aneurysm, monitoring of these complications of DCI, hydrocephalus, involving a teamwork philosophy, and getting a neurosurgeon also involved. And like one of the last studies we mentioned, early rehabilitation, early mobilization in these patients, and having a patient and family-centered care. So what are coming areas of potential areas of intervention? And these are so many areas of neuroprotection, neuroinflammation, thromboinflammation, vasospasm, apoptosis, and the endothelium. And all these areas are potential targets for neuroprotection, for therapeutic strategies. And this is something that was recently published 2021. And there's so many studies going on, phase 1, phase 2, and others are at phase 3 already, but still, there's still so much hope for this. So in conclusion, subarachnoid hemorrhage is an emergency. If you remember that slide that I showed you at the beginning, we're all set. Be aware that this is a potentially lethal condition that needs early intervention. The big three, vasospasm, rebleeding, and hydrocephalus, and how important it is to have multidisciplinary care, and most important of all, patient and family-centered care. So with this, I leave you. Thank you very much, and have a good night.
Thank you so much, Dr. Gloria, for the excellent and informative presentation. You covered everything from the beginning, from the risk factors, and not only
I think I missed him.
Yes,
to know the decline that
Dr. Adil, we missed the connection with you. Dr. Adil.
experience. Now, the discussion will reveal our audience for today. It looks, alhamdulillah, because the presentation very details and the sequence of the slides was very interesting, Dr. Gloria, covering all things. Yeah, the outcome, the prognosis, the complications, and how to deal with the complication and how to prevent before occurrence and happening. And if happen, how can we deal? These things is very important for the intensivist ICU doctors and to help the patient who develop subarachnoid hemorrhage. Still, we have 2 minutes. If we have any questions, if not, we can close the session. But really, we have a recorded fruitful and presentation and talk from Dr. Gloria all together. And you've done great job, Dr. Gloria, from the topics, the guidelines, the recent one, the updated one, covering everything regarding the aneurysmal subarachnoid hemorrhage, the treatment modality, the coiling, clipping, the study which shows the results. All these things help too much. Also, the lines of treatment, nimodipine and nicardipine, statin. No need for magnesium now, because before the practice, many doctors were using magnesium when the patient admitted. No need at all to avoid the hypermagnesemia from the beginning. The rule of anti-epileptic, if frequently administered, sometimes what is the consequences if we are giving this medicine unduly. All this, the MAB also, and what is the blood pressure allowed, the triple H, which is commonly, very commonly used. I think, as you mentioned here, no need at all. Maintaining euvolemia is more than enough for the patient. So you covered everything in the details for the ICU doctor in ICU department when receiving a patient with subarachnoid hemorrhage. Really appreciate Dr. Gloria.
Thank you.
Very nice. Okay. Thank you so much.
Of course, Dr. Gloria take us in a very wonderful journey, starting from the prediction and diagnosis, accurate diagnosis, steps of diagnosis ranging from CT, MRI, and lumbar puncture, then the actual treatment, the prophylaxis. I have a small comment, Dr. Adil, if you allow me.
Yes,
Dr. Gloria, if we have accidentally discovered the subarachnoid aneurysm, and we have an emergency operation now, what is, in your opinion, to have the priority to manage firstly of this condition? To do intervention with the subarachnoid hemorrhage to avoid complication during the second emergency operation, or to wait? What is the risk factor that I should control before going to an emergency, before clipping this aneurysm, for example?
So your question is if there's an emergency procedure, life-saving, and then you find incidentally a subarachnoid or an aneurysm.
Yes.
What do you find? Because if I mean, the first thing is the life-threatening, whatever is life-threatening, right? So you need to balance which one is more life-threatening. If it's an acute abdomen and you have the subarachnoid, then, and the patient is septic, then treat the acute abdomen, and then we'll deal with the subarachnoid. If it's an incidental aneurysm, treat the patient for what you are doing, and then do an evaluation. If it's an aneurysm, how will it be treated? Non-subarachnoid. I saw somebody, Mohammed Hamed, asking about case
Yeah.
reports of a subarachnoid hemorrhage following cesarean section. Actually, Dr. Javier Perez just published a book on the brain and the pregnant woman. So maybe Dr. Javier can talk about that later. But usually there's so many hemodynamics going on through birth that you can have a bleeding, and you will treat it as you would treat any other subarachnoid hemorrhage. It's an emergency. Try to diagnose if it's an aneurysm, and if it's aneurysmatic, secure the aneurysm and treat accordingly. So yes, there has been reports, and usually, not only following cesarean section, following birth, the birth process, because you have increased intracranial pressure, and that will have source of bleeding. And there's so many other hemodynamics during pregnancy that can also cause it. Yes, very good question.
Yes, yes. And
really, thank you, Dr. Safa. Also, Safa Hilal, Professor, you've done a great job also for the Egyptian Society, and we are all happy and interested to join these fruitful sessions. I think all doctors and all colleagues are so glad, so happy to join such kind of scientific session and programs. Really, you are doing great job, and we are all with you to support you whenever required and needed. And also, I'm so happy for the doctors who are joining and also interacting. Like we have eminent speaker today, Dr. Gloria. So we give a chance for all doctors, inshallah, to get benefit and to practice with the updated and recent guidelines as well. Thank you, Dr. Gloria, and thank you, Dr. Safa.
Of course, I am big zero without your support and your help. Thank you for your support by time, by effort, and thank you, Gloria, my dear friend. Thank you for your effort and time today. Thank you for Professor
Thank you.
Adils.
Thank you, Dr.
Thank you, Paulo, for your
Thank you, Paulo.
Paulo, starting the way.
I'm so happy Paulo study also. It was very interesting, and we hope one day we are all using the wearable new devices, inshallah, for pre-operative assessment as well. Thank you, Dr. Paulo.
She already wear it. Dr. Adil, you see, she already wear her smart hour.
Yes, mashallah.
Yes.
Okay, thank you.
Also, I'm sorry, so Dr. Khafer have disconnected because of error in network.
Okay, thank you. Thank you all. Wish you a very happy weekend. Thank you.
Bye-bye.
Dr. Gloria, I invited you to be one of the founder of our Egyptian Society of Anesthesiology and Acute Care. And I will add you to the group. Please accept the invitation.
Of course, it's an honor. It's an honor.
Yeah,
thank you.
Thank you. And we are waiting for more collaboration with you and more presentation.
Excellent.
Thank you. Thank you for finding. Thank you.
Bye-bye.
Thank you.
Bye.
Bye.
Thank you. Thank you.